Okay, can everybody see my screen? Great. Okay, so here we are. Welcome to our second Fabry and Female webinar. My name is Julia Alton, Executive Director of the Fabry CFA, sorry. And I'm really looking forward to this conversation. If you didn't get a chance to listen to our part one, you can find that on our website at fabrycanada.com. And it was a great conversation with Dr. Bichet and Sheila and Rebecca. And tonight we're talking about Fabry and females again, but this time we're doing a different topic. There's a lot of different topics to cover with females, and so this one is across the life cycle and the different things that females experience, like puberty and perimenopause, menopause, family planning, and how the body with Fabry works with the different cycles that we go through. So we are this webinar is also supported by Amicus. So thank you, Amicus, because this is a great and much needed topic. In the first webinar, we spoke about this white paper, and I hope that we can, yeah, you can kind of see it on here. You'll find this in some of the clinics around Canada and also on our website. The white paper is dismissed, unheard, and unseen. And we talked about this at the World Symposium, and it is a paper that was co-created by HCPs and patient organizations. Um, we the tough part about this conversation is we don't know everything we want to know yet, and we're still learning. And this is what this topic is about tonight. It's showing that we're moving in the right direction. We're asking different questions. We hear you when you're saying, you're having a difficult time when the symptoms overlap between these cycles. And so we're here, and our speakers tonight are here to share what we do know. And that's really powerful. And at the very end, we're going to open it up to questions as well. So in the chat, at the bottom of your screen, you'll have chat. Feel free to write your questions throughout, and we can get to them at the end. So without further ado, we will open it up to our discussion. This conversation matters to me because I think I mentioned this in the last one, but I was first told that I was a carrier. And you kind of live those few years of your life wondering exactly what that means. And it wasn't until I had symptoms that I was then told I had Fabry disease. Um, I have been through a few different life cycles and not all of them yet. And there's always so many questions that I have when I'm going through that and wondering, okay, is it Fabry? What questions do I ask for my doctor? What do I have to learn? What else can I do to support my body? And so this is why it's important to me. And I want to learn whatever I can so I can then have a better outcome. And, my quality of life is better. And I think obviously we know that knowledge is power. And it really, really, really is important to just do everything that we can in our control. So that's what this is about today. I'm going to ask Dr. West to go first. And Dr. West, why do you think this conversation is so important to you?
Thanks, Julie. I'm very pleased to take part in this webinar tonight. I'm a nephrologist in Halifax, for those of you who don't know me, and I look after the Fabry patients in New Brunswick, PEI, and Nova Scotia. And I also look after the chair of the guidelines committee, treatment guidelines committee in Canada, and head the registry group. But other than that, I don't have anything to do with Fabry disease. Anyway, why does this conversation matter? Well, it's extremely important. The majority of Fabry patients are women. Remember that this is a sexist disease. It's very different between males and females, and there's two females affected for every male. So females make up the majority of patients. So we better do a good job looking after them. Um, uh, and as Julia has highlighted already, I mean, there was a long-standing um, uh, concept which was wrong that females didn't have the disease, when in fact every single female with Fabry disease does have the disease, does have some symptoms, does have some findings. Some of them may be very minor, and those women may not be terribly affected, but other patients can be severely affected to the point of uh, problems with requiring organ transplantation or even reduced survival. So it is a very important condition in women. And so that message needs to be continually highlighted, I think, because many women and male patients haven't really um, grasped the correct position on this. So I'm pleased to take part in this conversation.
Thank you, Dr. West. So Sheila and Rebecca and myself are both nurse clinicians here at the Fabry Clinic in Calgary, Alberta, with Dr. Neil Kahn.
Yeah, so Sheila's got a bit of a
I have a
cold,
bit of
so
a
we're
cold.
going to tag team if she's coughing, but that's great because we all need our people. So that's what we're doing today. So this conversation matters to us, as Dr. West said, because so many of our patients are female. Our clinic visits are so busy, and there's so many data points that we're trying to capture. But what matters to us may not be what matters to you as a patient when you come. So knowledge is power. So the more you understand and you know what questions to ask to your friendly Fabry doctors and nurses, we can help you avoid diagnostic delays and try and move forward in your care.
Yeah, and so as the white paper quote, I can say, seeking care tailored to needs, not gender. So not comparing male to female, but let's look at you as a unique person. You are the expert, and we're here to see how we can support you on your journey today. So thank you for having us.
So as Julia mentioned, she's just props to Julia and Donna with the CFA. You've done an amazing job at creating educational events, webinars, handouts, papers. So we won't go into all of what Fabry disease is, how it affects you, because we did some great webinars a couple weeks ago, and there's more on that fabrycanada.com if you want to go look it up, or .ca. I actually can't remember. Julia will correct me at the end. But this is just a quick picture of the organs that are involved with Fabry disease. So your heart is involved, your GI tract, especially as women, we hear that a lot. The acroparesthesia, that pain to your hands and toes. You may get the little dots, angiokeratomas. So your skin, your endothelial cells are affected. Also neurology. So your brain can be affected, your kidneys and hearing loss, eyes. It does affect as a whole system disease. And that is affected. So the more you know, the more we know what to watch for. And we talked about this a couple weeks ago and why we test what we test at the clinic visits. So pop on over there to the next one. So this is from the Fabry outcome study. It shows some clinical manifestations in this cohort of patients. There was a closer match, male and female, in this from 19 different countries, but it shows, as we just said, some of the age of onset of these different symptoms. So cardiac disease, 35 years is when they started noticing symptoms in females, 39 for renal, 36 for the cerebrovascular, that neurology component. Flip to the next one there, Julia. So we're going to tag team a little bit between Sheila and I and Dr. West, and we're going to talk about some of the hormonal things that happen, starting with pregnancy. It's not a given. Not every woman will have a pregnancy, but it's something worth talking about. So there are impacts to consider. So pregnancy is magical. It's beautiful. It's wonderful. And it's stressful. It's exhausting, fatigue. And if you have Fabry disease, there are extra implications to think about as your body is supplying nutrients to the fetus, supporting development, and preparing for birth. So for patients with Fabry disease, this process can make your heart and kidney symptoms worse. So the next slide here, we'll see pregnancies complicated by Fabry disease can have a higher risk for some of these symptoms. For example, proteinuria, we see that says 37.2%. Dr. West is going to talk more about this later. Significant proteinuria, oh, go back one there for me, Julia, thank you. Significant proteinuria is in roughly 8% of the healthy population, so 1 in 12 pregnant women. And in women with Fabry disease, it's roughly 1 in 3. So we'll see that in a little bit later. And I'm sure you've heard us talk about proteinuria or heard your physician talk about it. It's an early manifestation in Fabry disease in females. And if you think back 2 weeks ago, if you joined us, our friendly Dr. Bichet talked about the podocyte, and you get to go back and hear him talk about it, but the podocyte and how when that GB3, that recycling, that substrate builds up in the cell in the podocyte, it breaks down the ability to filter protein. So that spills into the urine. And this proteinuria can cause higher blood pressure by damaging the kidney's filtering units. When you're pregnant, you have a lot more blood volume, so there's more blood to filter, so that also contributes to this. And your kidneys can trigger your hormones that narrow the blood vessels, which leads to high blood pressure. That's just kidneys, and I'm not going to say more because our friendly nephrologist is going to chat more about that later. But these other things, acroparesthesia, so that burning to your fingers and toes that you may feel on a daily basis anyway, can be worse in pregnancy. You're growing a little furnace there. So there's significant heat changes in your body, can worsen with stress, fatigue. And then, of course, constipation, diarrhea. When you're pregnant, you're eating differently. You're eating more. There's hormonal changes. So, of course, that's going to affect your GI tract anyway when you already have challenges with Fabry disease in your GI, and also headaches. So pregnant women with Fabry may experience pregnancy complications. And we're going to go to the next one, and I'm going to throw it over to Dr. West, who's going to speak to the numbers on this slide.
Thank you. So these data are from the Dutch group in Amsterdam, and they have big Fabry clinic there. In fact, they have a Fabry clinic there for the whole country because it's so small. Anyway, so they've published a number of papers, and these data are from looking at symptoms in female Fabry disease patients compared with controls, women without Fabry disease. Oops, just go back. There we are. And so these here relate specifically to issues around pregnancy. So the first line, they're talking about hypertension during pregnancy, and it was around a third of the Fabry women, compared with only 14% of controls. So was more common in the women with Fabry disease. And also proteinuria in pregnancy was again a third versus 0% in the controls. And those were statistically significant. In other words, the numbers seen in the Fabry patients were elevated and more likely to be a true observation with this. When they looked at other complications, you can just go down the list there: bleeding, large babies, small babies, retained placenta, miscarriage, intrauterine deaths, induced labor, etc. The prevalence was about the same between Fabry patients and controls. So why is that? Why are women with Fabry disease having more problems with proteinuria, that is protein in the urine, and hypertension during pregnancy? And I'll talk a little bit more of that later on, but it is part because of the Fabry disease itself. Women with classic disease are more likely to have protein in the urine as well as hypertension because of underlying involvement of the kidney with Fabry disease. And this is a problem because this can lead to other complications during pregnancy. Okay, so we'll move along from this slide.
So these numbers come from a study, a retrospective. It was more of a survey than a study. So I'm not going to pay attention to the numbers specifically because these numbers came about from a study where these women were asked to recall events from their pregnancy. And I don't know, I can't even remember what I had for supper last night. But when you have a little baby and you're postpartum and your hormones and you're asked to remember all the things that maybe your doctors told you, you may have some recall bias. So the writers of this study did note that. But what we can learn from glancing at this is that women with Fabry disease should be aware of these potential worsening symptoms. So it is a bit of a broken record. We keep saying this already in the first 15 minutes, but being aware, knowledge is power, what could happen. Pregnancies with Fabry disease are considered high risk. So no pregnancy is risk-free in any population. And we are not suggesting that you shouldn't get pregnant, but rather that you will benefit from some consulting perhaps with a maternal fetal medicine specialist, a high-risk OB, doing some genetic counseling beforehand. We'll talk about that a little later, but it's very important that you are monitored throughout your pregnancy with the appropriate people to treat these symptoms as they come. It's also important to note that in Canada, there are no licensed or approved therapies while you are pregnant with Fabry disease. So continuing on ERT, if you are, is a decision that will be made between you and your healthcare provider, and there's a risk versus benefit there. So we're not going to speak to that specifically in this webinar. But the normal standard pregnancy encouragement, don't drink, don't smoke, make healthy dietary choices, plan for your pregnancies if at all possible. And if it's an unplanned pregnancy, let your healthcare providers know, because we are on your team and we want to have the very best outcome for you. So the next one there, Julia, we talked more about this in the last webinar, and there's lots of information about this on the CFA website too, but it talks about the inheritance for when you're doing family planning. So on the left there, from an affected father, a father always passes his Y chromosome to his sons, so they will never have Fabry disease. He passes his X chromosome to his daughters, so they always will have Fabry disease. This is an X-linked disorder. So on the right-hand side, an affected mother, so somebody with a woman with Fabry disease, who is planning pregnancy, planned or not, you have a 50% chance of passing that affected X to each child, whether male or female. There are cases when the gene mutation may occur for the first time in a family. It's called de novo mutation, but of course we don't plan for that. So if you are a woman with Fabry disease, there's a 50% chance that you will pass that on. Having said that, in the next slide, it is 2026, and there are some pretty amazing options out there. We are not experts on this by any means, which is why at Calgary, if you are a patient, we would refer you on to the regional fertility program or to our genetic counselors to discuss your options. There's lots of options here, and maybe at the end we will have time for some lived experience. Some people could share your experience with this in your province. Access is not the same in every province. It is not covered in every province or by every healthcare plan. It is a very expensive process. So it is not equal everywhere, but there are options around genetics and pregnancy. There's no single right choice for everybody. Family planning decisions are very personal. They're complex. And there's a lot of clinical context that has to go in with how your symptoms are in Fabry. So I'm going to pass it off to Sheila here because we are talking about menarche and menopause. So the polar opposite ends of the hormonal fun that comes with being a woman. So this study here shows that age of menarche, when you first get your monthly, your period, your cycle, is roughly the same in individuals, women with Fabry disease, teens, really, teenagers with Fabry versus not. But there are some slight differences at the other end with menopause.
Yeah. So next slide. It's a fun bubble that talks about this word menopause. So many things, right? When we look at this bubble, symptoms that are so unique to each woman. Some women are affected just minor, and some it affects their entire quality of life. So things on here like fatigue, mood swings, weight gain, especially osteoporosis. We'll talk about that in a little bit, about how your bones will change. Even bladder issues, you might see some bladder leakage. We talk about low sex drive, irregular periods leading up to it, breast density changes. So lots going on here, and many people have many more symptoms. Poor sleep habits, hot flashes, night sweats, just that feeling of overheating. So we'll talk a little bit more about, break this down. Next slide. So yeah. So menopause, let's just state that menopause is a regular phase of life. It is a normal phase. It's not abnormal. Every woman will reach this stage. Women are born with a finite number of eggs at birth. From the time they are born, they have approximately 1 to 2 million eggs. In comparison, men are making that sperm daily, up to 1 million each day. So quite different. So women over time that quality of those eggs begins to change. That quality goes down, and that causes those irregular periods, and ovulation pretty much becomes irregular, and it affects the hormone production. So the estrogen and progesterone production decrease. And menopause really marks the end of that regular menstrual cycle, and it's diagnosed after having 12 months of no periods. And like we said earlier, menopause, those symptoms vary widely. So each individual is very unique and very different. So what I would like to draw attention to on this slide is that we do need to acknowledge that these symptoms exist. Your physicians cannot read your mind. So if you are having symptoms and you're going to your doctor's office, it's really important you verbalize those symptoms so that we can help you intervene and manage what we can for those. And I think Dawn had a really good point. She's a genetic counselor, and she made this point during a THIN meeting, and she just said, people with cancer or other diagnoses, they walk into doctors' offices all the time, and they don't question if their words are going to matter. So if they make statements like, I'm feeling fatigue or I'm feeling pain, their statements are taken at face value. So I just want to reiterate that here. You have Fabry disease and your symptoms matter, and we want to take those at face value too. So don't ever think that we would not. Next slide. So when we talk about menopause, we do talk about the stages of menopause. And menopause typically occurs between 45 and 55, with the average being around 51 in Canada. And it looks to be that Fabry women experience this at no different rate, average 51 for Fabry women as well. So perimenopause is that time that leads up to the end of the cycle, where those estrogen levels are fluctuating, symptoms might be beginning, changes in your flow, you might start getting some night sweats, breast tenderness, sleep problems, you might start to notice your mood fluctuating. So that's perimenopause. And then we talk about the menopause diagnosis, which is consecutive 12 months with no period. And that starts to really signal the drop off of estrogen and then the stopping of ovulation. And then the part that comes after that is postmenopause. And that's the part we really need to watch. So that's where we stabilize to that low level of estrogen, but then we have some other concerns that can come into place, like osteoporosis and cardiovascular disease. And we'll just go to the next slide. So I think it's important when we talk about menopause and we talk about, estrogens dropping, I think it's important to talk about what does estrogen do in the first place. So a big part of estrogen's job is to help your bones. So when we think about it, it's about making deposits into your bone bank. So think about deposits and withdrawals from your bone bank. So leading up to menopause, estrogen can help your bones just become stronger. So they help suppress that inflammation cycle where cytokines can come in and can trigger bone breakdown. Estrogen helps absorb the calcium from the foods we eat. It works with the cleanup crew, and that cleanup crew is called the osteoclasts. And estrogen tells those guys to die off a little sooner to prevent excessive bone loss. And then it works with helping the osteoblasts, which are the building crew, works to help them activate and stimulate them to build new bone in your body. So interesting fact, your body is constantly going through a turnover. So bone renewal is a lifelong process. And every year, this was new to me, I just learned this, 10% of your skeleton is rebuilt. At age 30, the rate of breaking down old bones begins to exceed the rate of building new bone. So we'll go to the next slide. I was going to hand this over to Dr. West, and I'll let him share his input here.
Thank you. So patients with Fabry disease have been studied in terms of their bone mineral density or bone density. And this is something that changes, as you've heard, over time. So as we all age, our bones get thinner. But in Fabry disease, it's been noted that the bones were thinner than they should be compared with the general population. And there's a number of reasons for this. One of the most common ones is if people have underlying kidney disease. So if women or men with Fabry disease have chronic kidney disease with decrease in kidney function, then there can be what's called secondary hyperparathyroidism. So there's a reflex increase in secretion of so-called parathyroid hormone, and this is a peptide hormone which acts to break down bones. So, so that explains why some of these patients with Fabry disease will have thinner bones, but it leaves about 75% of patients with Fabry disease for which this uh, reduction in bone density is not explained. These data here on this slide just show you the decrease in the bone density measurements in this column in the middle with postmenopausal women compared with um, and it's with premenopausal women in the right-hand column. So there is lower numbers for bone density in the postmenopausal women. So there needs to be more research done. There have been some longitudinal studies looking at the effect of treatment of Fabry disease on bone density in women with Fabry disease. So they've looked at enzyme replacement therapy, and they have not shown that this makes any difference at all to the decreased bone density. So it doesn't prevent it from going down, and it doesn't correct the low density back to normal for women with Fabry disease. The other thing that's been shown is that these bones actually can contain an excess of GB3. That's the lipid that accumulates, fatty material that accumulates in Fabry disease. So it's actually been found in bone when they've tested for this, although it hasn't been measured very often. But in cases where they've looked for it, they've found it. So it's possible that the GB3 fatty material is somehow responsible for the decreased bone density. Perhaps the fatty material is displacing bone out of the bone. And anyway, we don't know about that. The other thing is that the bone density correlates with lyso-GB3, which is a biomarker in Fabry disease. It's a breakdown product of GB3 as its name suggests, lyso-Gb3. And so the higher the lyso-Gb3 levels are, the lower the bone density is in some women with Fabry disease, suggesting that there is a direct link between Fabry disease and this decreased bone density. So enzyme replacement therapy doesn't help. The situation has not been studied in patients who are taking oral chaperone therapy, megalostat. So we don't know whether megalostat would have a different action on in women. So that's an important study that for you people from Amicus who are listening to this. All right, so we'll leave this slide and move on.
Okay, so just looking at what else estrogen does quickly, it keeps that good balance between good and bad cholesterol. It makes those blood vessels dilate and helps just help with the blood flow in general, relaxes those vessels, and it can protect the heart from stress, increases your production of serotonin, which helps to stabilize your mood. We know it helps manage energy, so where it helps to direct where the fat is stored in your body. It stimulates some collagen production, so decreasing that stiffness. And then urinary tract protection, it helps maintain the lining of the urethra and bladder and neuroplasticity. So, and when we talked about that, it's just relating to the fact that it can help your body to adapt to new information and experiences, allow it to constantly rewire itself. So estrogen has a big role to play. So when it drops off, we can see where many of the systems in your body would be affected. We'll just go to the next slide. So then we have Fabry disease and menopause. So Fabry disease we know is characterized by that endothelial dysfunction. The buildup of the GB3 can change that, progressive cardiomyopathy and heart symptoms, and then increased cerebrovascular risk. So for things like stroke or TIAs, changes to the brain and the small vessels. And then loss of estrogen, independent of Fabry, can also increase your vascular stiffness and endothelial dysfunction and increase your cardiovascular risk and also accelerate bone loss and metabolic changes. So you combine these two things, and menopause can act as an accelerant for Fabry symptoms. And a lot of Fabry symptoms can overlap with menopause. So when we have to look at and break it down, so when you look at things like, say, for example, forgetfulness or white matter changes to your brain, we need to ask the question, is it Fabry disease plus menopause? Is it menopause symptoms we're experiencing? Same with joint pain. Is it Fabry disease? Is it menopause? Or is it Fabry disease and menopause? So we need to investigate and rule out some other causes. And we need to really, when we go to these visits, kind of investigate that. So if you go to these visits and you're given a treatment for something or one of these symptoms, I would encourage you to ask, did the treatment make the symptom better? Did it change anything? And possibly some of these indications like increasing cardiovascular disease or increasing cerebrovascular risk, we need to think, is it time to start enzyme replacement therapy? If you're not on it, is it time to start it? So I'll go to the next slide. And so hormone replacement therapy in females with Fabry disease, there isn't a lot of guideline recommendations specific to this hormone replacement therapy in use with Fabry disease. Many of our clinics do not prescribe it. So I would encourage you, if it's something that you feel is something that would be useful to you, that you advocate at the time of your clinic visit for a referral to a specialist. So somebody like in endocrinology or gynecology, someone who can help you assess the risks and benefits of hormone replacement therapy with Fabry disease. And again, I'll go back to the white paper pages, and there was a quote in there. It said from Lana from the US, and she said, "You deserve care that reflects your reality." So if you're struggling with symptoms of menopause that really changes your quality of life, I would just recommend that you really advocate for that second opinion and see if hormone replacement therapy is something that would be useful for you. And I'll take that over to Dr. West now.
Thank you. So I'll just spend a couple minutes talking about our current Canadian Fabry treatment guidelines as pertaining to females. So our guidelines have been in existence since 2005, and they've been updated pretty regularly, although the last time they were updated was 2020. So, and then we had COVID and a few other things. So we're due for another update. So the current guidelines are designed to provide treatment to patients who will benefit from that treatment, recognizing that there is certainly a treatment burden particularly for enzyme replacement therapy, but all treatments have risks as well as benefits. And so that needs to be balanced against what are the benefits of therapy. And we want to use these drugs wisely because they are all somewhat expensive, and there's no drug that doesn't have some potential adverse effects. So all that needs to be balanced. The guidelines do not distinguish between sex, so we are treating patients who are males and females according to the same criteria, and we also have these same criteria for children versus adults. And you can criticize our guidelines for that, that's fine. But if you look at the prevalence of treatment in Canada, that is, what percentage of Fabry disease patients are getting treatment in Canada, it's really about the same as elsewhere in the UK, France, Australia, where they have guidelines. And it's similar to what's been reported in the industry registries as well. So I don't really believe there's a big difference. So on this slide is just a brief summary of treatment. This is the non-specific treatment. So we've already mentioned genetic counseling. We want to control risk factors for blood vessel disease, strokes, heart attacks. So high cholesterol, smoking, high blood pressure are all important risk factors that we need to eliminate from patients. So we need to work with them to ensure we have these under control. Controlling pain is critically important in patients. And it's the first thing I try to do when I see a new patient is make sure that we get their pain under control as well as we can. And we thankfully have lots of drugs which work pretty well to do that. So there's a wide selection. We want to prevent stroke in patients that have had stroke. So we use drugs like ASA and clopidogrel. We want to limit urine protein. We've already heard that urine protein is bad. And so if we reduce the urine protein, that will reduce the risk of some of the complications of urine protein. And there's, again, a whole bunch of drugs that do that. But enzyme replacement therapy and chaperone therapy does not decrease urine protein. So there has to be additional therapies provided to any Fabry patient who has protein. If it's just a little bit, they might not need specific therapy, but as the urine protein increases, then physicians are more likely to add from that list of drugs I've listed there. Um, and the multidisciplinary team is important with nurses, social workers, dietitians, um, and occasional physicians. All right. So at the same time that we've added specific therapies over the last 20 years with chaperone therapy and enzyme replacement therapy, we've also improved our basic treatment. So we know patients are doing better, but it's due to a combination of the specific therapies and all those non-specific things I just reviewed with you. So it's hard to separate the two. So who are we treating? Well, we're treating patients that have evidence of organ involvement. So that is heart, kidneys, strokes, that sort of thing. Um, and we have broken things down into 5 domains: kidney disease, heart disease, strokes, uncontrolled GI symptoms, and neuropathic pain. Um, and so someone can qualify under just one of these things. You don't have to qualify under all, and the disease is quite variable. So we wouldn't expect someone to have features under all these different domains. And certainly we don't want to see a patient like that. They would be very miserable. So going to the bottom, neuropathic pain. Again, if there's a failure of these other drugs and we want to have people on specific therapy with enzyme therapy or chaperone, we leave the specific decision as to what type of drug and which drug to use up to the treating physician and the patient. So the guidelines aren't specifying a particular therapy. We're just saying if you meet if you meet these criteria, then we're recommending you start a therapy, whether it's enzyme therapy or chaperone therapy. That's up to the treating patient and physician. And right now we have 3 versions of enzyme therapy. There's a new one now, so 3 versions of enzyme therapy and 1 chaperone therapy. Uncontrolled GI symptoms like diarrhea, abdominal cramps, vomiting, nausea, um, will respond to enzyme therapy and chaperone to a degree. They're not cures in any ways, but they can certainly make a difference in terms of these symptoms. I've had some patients with diarrhea every hour. They're unable to work, spend all day in the bathroom, and they couldn't get it under control till they got on enzyme therapy. So can make a big difference. Patients who have strokes or mini strokes, what we call TIAs, we treat them. Acute hearing loss, sudden loss of hearing, we consider to be due to a blood vessel problem in the inner ear. So it's akin to a small stroke. So that's why we'd want to treat those patients. Now we know that enzyme therapy and chaperone aren't going to bring back the hearing, but it may prevent them from losing hearing in the other ear. So it's important to treat these patients. In terms of heart disease, there's a whole bunch of different criteria we can use to qualify patients. We look for changes on the EKG, on the echocardiogram, that's a sonar study of the heart, and on a heart MRI, that's a magnetic resonance imaging. And also on a Holter monitor, which is a 24-hour wearable EKG. So we're looking for changes in heart rhythm, heart rate, the thickness of the heart muscle. Um, we're looking at changes in how the heart relaxes, how well the heart muscle cells are working, and We're also looking for the presence of scarring on the cardiac MRI. When they give that gadolinium dye, it will light up areas of scar in the heart. So that's critical to look for that, because women may have scarring on the heart before they get any thickness in the heart. So if you're just doing echocardiograms, then you may miss a female patient who's developing very serious, irreversible heart scarring if you don't do an MRI. And we also look at things like troponin T and this pro-BNP, which are biomarkers that become elevated with increasing damage to the heart muscle. So currently, if someone has two of these cardiac factors, then we would want to start treatment on them. When it comes to the kidney, we're looking for a decrease in kidney function. Um, and it doesn't have to be below normal, but it could be one that was quite elevated. So some patients get elevated kidney function when they get kidney disease, and then it falls over time. So even in that situation, we would want to treat patients. If they show evidence on a kidney biopsy of Fabry disease, we think that would be a reason to treat someone. Even if they had normal kidney function, but we don't require patients to have a kidney biopsy, but sometimes patients are recommended to have that. In terms of women, the risk of developing end-stage kidney failure is 20 times less that of men. Okay, so women are relatively protected with Fabry disease against running out of kidney function. So the men have terrible risk. If they live long enough, they're all going to end up on dialysis. But the women, that doesn't happen. So, in fact, it's in my clinic, which I've been running since 2004, and I have 120 patients. I've never had a woman end up on dialysis. Never. So it doesn't mean it doesn't happen, but it's unusual. So for women with kidney disease, it's mainly going to be protein in the urine that gets them into trouble. Um, so protein in the urine is very common in women with Fabry disease, but they don't have progressive disease generally. They don't end up needing dialysis or a kidney transplant. But as you've heard, the protein in the urine is not a good thing. All right, so that's how currently the treatment is determined in Canada. Um, Although I think there'll probably be some changes with the next version of the guidelines. Okay, last slide, I hope. I've already talked a bit about balancing treatment benefits versus burdens. There are a number of Fabry female patients in Canada who've been offered enzyme therapy. I've got a few who have refused. And, they clearly meet the treatment guidelines. They may have heart disease, they've had strokes, other bad things have happened, but they decide they don't want ERT, enzyme therapy. And I think some of this is because they realize that it comes with a burden. It's IV, it's every 2 weeks. They might have to travel to get to a treatment site. There can be infusion reactions. There can be anti-drug antibodies that cause problems. And it's a high cost. And although in Canada with publicly funded healthcare, cost doesn't come back to the patient directly, but in some provinces in Canada, they have to pay a copay, and that's a problem. So in PEI, women have to pay, a 20% copay. They ultimately are reimbursed by government or by industry, but they have to pay out of pocket first, and they only get reimbursed by industry. So anyway, so the rest of the provinces, that doesn't happen. So don't move to PEI. Next slide. My last slide. So just a little bit more about proteinuria. So proteinuria is very common in women with classic Fabry disease, but it's usually very low grade. It's under half a gram a day. So normally we all have a tiny bit of protein in our urine, about 0.15 grams a day. So in pregnancy, this goes up. So all women with pregnancy most of them will spill a bit more protein in the urine because the kidneys work harder during pregnancy, and that's caused by the changes in hormones that come with pregnancy. Um, and so women with Fabry disease that have proteinuria are going to have a bit more during pregnancy. And the fact that women may have increased protein in the urine prior to pregnancy is a risk factor for further kidney problems during pregnancy, what's called pregnancy-associated hypertension or high blood pressure. And the more severe form of that is toxemia of pregnancy. And these complications are serious because they can do two things. They can harm the fetus, and so we can end up with a small for dates baby. You can have a premature delivery, and some fetal deaths in severe cases. Um, and the other thing that can happen is that pregnancy can worsen chronic kidney disease in women. Uh, um, and this would apply to women with Fabry disease. So it happens related to all kidney diseases, but it will also happen with Fabry disease. So that means if you have a lot of high blood pressure during pregnancy and toxemia, then you can have permanent damage to your both kidneys. And so if you have poor kidney function going into pregnancy, by the end of your pregnancy and you've delivered, you may have a significant decrease in kidney function at the end, which is permanent. So because of that, those risks, it's very important that women who with Fabry disease who do have proteinuria, that's increased protein in the urine, are identified and are sent for appropriate close monitoring during pregnancy to a high-risk pregnancy clinic. So that's important. And I referred one of my patients just last week. So it's not uncommon. It should be done, and it's not specific to Fabry disease, but also important. And certainly other risk factors during pregnancy are high blood pressure and smoking. So those two things are very important to get under control or to stop. So I'll stop there, I think.
Thank you, Dr. West. Um, I'm listening, and I just want to say, if anyone's listening and they're feeling a little overwhelmed, I want to say I think that that's normal. Sometimes when you really take in all the ways Fabry affects us, the knowns and also the unknowns, it can just be overwhelming. And then layered on top of this is trying to understand, how different hormonal phases feel in our body, how they can influence our symptoms. It's really just a lot to navigate. And I wanted to say that because I think I find myself sometimes in like these meetings or on these webinars and being like, whew, this is a lot to take in. And that's a normal human experience, and so I think that something that helps me is I mean, certainly having these great healthcare professionals on our team with us. I think, Dr. West, I like when you said the majority of Fabry patients are females, so we better do a good job of looking after them. And Rebecca, when you're saying, we are on your team, we want the very best for you. And I think that that's something that we play in our heads when we're walking into our clinic visits, being like, okay, Sheila said, your physicians can't read your mind, and you have Fabry disease, and your symptoms matter. So all of these things are really important because when you're walking in, you want to remember these as you're kind of walking into these appointments. Um, because it can be overwhelming and it can be easy to just be like, "Oof, you know what? This is all just too much." But this is why we're here. We're here to be educated and we're here to be empowered. On the next slide, you'll see some questions, and questions are really important too. So then you walk in, and here's are just some guided questions that you can ask your physician or just have a conversation about. Um, so here's a few in the reproductive years and family planning. You can just take a look or you can take a screenshot if you want. um, Pregnancy and post-pregnancy. So how could Fabry disease affect pregnancy? What are the additional monitoring that's recommended? And how can you even be your own advocate when you're going through the beautiful phase of pregnancy, there's a lot of different symptoms. So a lot of good questions you can ask. Perimenopause and menopause, being able to really decipher between is it Fabry or is it menopause? And not being scared to ask those questions in your physician's office. And questions all throughout our different life stage. So we also want to open it up to all of you. And any questions that you have, we want to help you get those answers. So you can turn your video back on, or you can put it in the chat, and we'll throw that over to everybody. So thank you very much, Dr. West, Sheila, and Rebecca, for being here. You guys are just such a pivotal part of our community, and it shows in all these ways. And Amicus, thank you for supporting this to give everybody this education. So let's check it over. Let's check the chat. So all resources would be appreciated. Engaged in a women's midlife course at Harvard, and interested to know where I can find information and research.
Yeah, and I might just say, Julia, you said come off mute if that's okay. I will.
Yeah, go for it.
Thank you so much for actually including the kind of mid and post life part of being a woman. This is like the last third of our lives is spent in menopause. Say nothing about peri that happens before. So I really appreciate that this is the first time I've been on a webinar about women and Fabry, and it was very specific. While limited, because it is limited, I get it. Talking about, that it is the overlapping symptoms are unbelievable when it comes to peri and menopause symptoms and Fabry symptoms. So I would love to just kind of know if anybody's read a good book or has some good resources in their toolbox. Certainly, maybe the providers do too. Would love to hear. Thank you.
Yeah, I think there's not a lot of research, definitely not when it comes to Fabry and menopause, as you probably know. And I think there needs to be more, and that's something we need to advocate for. This is an area that is lacking for sure. And we can share our resources from where we got our information today on this slides. But yeah, I found that as well. It is difficult to find information. Peer-reviewed journal articles, there's a handful, but it is tricky.
You're taking the course. If you find resources, share them our way too.
If
We
I
need
can
a sponsor to take this up as their mission to study. Dr. West.
I'll just make a quick comment. I think it is very difficult to evaluate symptoms. If fatigue is the most common symptom in Fabry disease, we still don't even understand what causes it. Maybe it's due to altered cell energetics. We don't know. And it doesn't really respond very well to treatment. So, it's, and all the other things that go along, all these symptoms of the perimenopausal and menopausal time of life really overlaps so much with Fabry disease. And I think these things are probably additive, which doesn't help. And how do you sort out one for the other? And the same goes for pain. There's different pain syndromes that people have. And, classically Fabry pain is in the hands and feet, but we know that it's not just in the hands and feet. It can be virtually anywhere. And that pain pattern changes from one person to another. It changes over time. And so one has to be, I think, be thinking very broad-mindedly about these symptoms and trying to tease out what they're related to. And that takes time. And sometimes it takes me a couple visits with a patient to try to really kind of figure out, their pain and things like that. And sometimes you can't figure them out. You just try something, and if they respond, great. So, it is a big challenge for clinicians looking after Fabry patients to sort this out. And I know it is tough for patients because they hear, oh, it's your Fabry disease doing this, or on the other hand, and they know it's not, it's something else sometimes. And sometimes it's the other way around, people don't pay enough attention to their Fabry disease because they're still thinking in the back of their mind they're a carrier, that they don't have disease. Um, so yeah, I think there's big challenges for clinicians to be able to be tuned into patients and particularly female patients to try to figure this all out.
Really like this question from Julie's iPhone, because this is a topic that is really high on the list for this year. I feel like are SGLT2 inhibitors recommended for all Fabry patients? This is something we're seeing more of in our clinic being used. And maybe Dr. West, if you have a comment on that and where you're at in the East.
Okay. The short answer is no. No, they're not recommended for all Fabry patients. These drugs are used for patients who have proteinuria. It'll reduce proteinuria. It'll help control blood pressure, help stabilize decrease in GFR. Not many women will have that. And the amount of proteinuria women will have generally isn't high enough to need one of these drugs. They're more likely to end up needing an SGLT2 inhibitor for so-called diastolic heart failure, which occurs as the heart gets thickened with cardiomyopathy in Fabry disease. And these are the first drugs we've had that have been shown to be of benefit in diastolic heart failure. So to me, it's very exciting that they are available, and I am prescribing this for Fabry patients with either heart failure or significant kidney disease. So I have prescribed it to some of my patients, but you can't give them to patients with type 1 diabetes. You can't give them to patients with GFRs less than 30 because they're not licensed below that.
And I think our clinic agrees with that. We often see it in our cardiology patients impacted with Fabry.
So Amy in the chat here says, how often does the CFDI recommend us to be seen either in person or via Zoom with our clinics?
Oh.
Dr. West, is your official recommendation?
Well, the answer is it depends. It depends how old you are. If you're a 6-year-old girl, you might not need to be seen very often, particularly if you're asymptomatic. And you might have been diagnosed on cord blood testing at birth, so you don't have any symptoms. So why do you need to be seen? Probably not till you get older, over 10 and 12 or so. So I think pediatrics are a separate group. In terms of adults, I think it depends also on your sex. If you're a young adult male, like I want those patients on treatment as early as possible. So I'm going to see them pretty often, like every 6 months, while I'm getting to know them and we're getting their test results back. And I'm looking for a reason to start them on therapy. So I want to see them often so I can evaluate their pain. If it's not under control, that's an indication for therapy. We need to adjust their meds to try to get it under control. So I'll see them every 6 months. Once patients are stabilized on ERT or other therapy, chaperone therapy, and they're stable, then I don't need to see them more than once a year. And the testing that's done, some of our tests are done annually for kidney function, protein, EKG. Those are cheap tests, echocardiograms. But more expensive tests like cardiac MRIs, brain MRIs, we do every 3 to 5 years, depending on the patient. The cardiac MRI is one of the best tests, but it is far more expensive, and it's a rare resource. It's hard to get those tests done, but to me, it is one of the best tests we have because it shows scarring on the heart. None of our other tests show that, and it will show low T1 values early on, which indicate fat accumulation in the muscle cells. So it can be an early indicator of Fabry heart disease, and we would treat patients on the basis of this low T1 value. So, so I do cardiac MRIs in my 18-year-old patients as a baseline. And sometimes I'm surprised, a 20-year-old will start showing a little bit of scarring or a low T1 value, and they'll end up on therapy as they should. But if I had to delay that MRI till they were 30, then I would have missed the boat by 10 years. So, um, and for patients who have late onset disease, things don't start happening till they're 40. So I'm not going to waste their time and money in the healthcare system doing a lot of testing before they get into their 40s, right? Because you're not going to turn up much. And so, yeah, I see those patients. I do follow them, but I don't follow them every year. Um, and once if they do end up on therapy, the men particularly, then I'll see them every year. Okay.
So Amy, we see your later comment there. Thank you, Dr. West. I see Amy chimed in a little bit later again and said 46 years old and on ERT. How often? So at least annually. So I hope his explanation has helped there. More specifics are very patient specific. And there's a great question here in the chat. We're going to ask Sheila first. Can the fatigue come from the heart because of arrhythmia? I was just asking myself this. So thanks for that question.
Well, yes, absolutely.
Definitely.
Yeah, when your heart is not functioning at the optimum rate and its ability, absolutely. Blood flow is affected. And we'll let Dr. West chime in there, as I think it pairs well with your last comment about cardiac monitoring and treatment.
Sure. Yeah, atrial fibrillation is, one of the most common arrhythmias that goes along with Fabry disease. And certainly people do not feel well with atrial fibrillation, even if the rate is well controlled early on. There's a period of adjustment, and so sometimes they won't even notice it after a couple of years, but early on, certainly they can get very, very fatigued. If you got very slow heart rates, some people are down in the 30s, low 40s with Fabry disease. That can contribute to decreased cardiac output and decreased blood flow and fatigue. And heart failure, which is a more advanced form of Fabry cardiac disease, also is associated with severe fatigue. So lots of reasons how heart disease can contribute to fatigue in Fabry disease.
I'm not sure how we're doing for time here, but there's another question here, just about allergic reactions to treatments. And yeah, that's something definitely to, I guess I should say the whole question. A woman or a young have a reaction allergy about a treatment. Did you ever think about giving half of the treatment instead to give the full treatment? And we'd ask you to seek just consultation with your healthcare provider and your prescriber, because there are pre-treatments that can be done prior to receiving the medication that can assist with any type of allergic reaction. And we do recommend that.
I would just comment that we get infusion reports after each patient gets enzyme replacement therapy, and the nurses usually would record if there's something going on. If they have a reaction, they're supposed to call the physician. But I always ask my patients in clinic if they're having any reactions, and it's curious because sometimes these reactions are not reported or not recognized by the infusion nurses, but the patients are definitely having infusion reactions that need to be treated. And so you always have to be suspicious about that, or be aware of that. And we do have treatments for these. Generally, we slow the infusion rates down, and we can give prophylactic drugs, which include acetaminophen, antihistamines, and sometimes prednisone, which is a powerful anti-inflammatory drug. No serious allergic reactions to chaperone therapy, but certainly all the forms of enzyme replacement therapy are subject to some allergic reactions. The only good news is that the neutralizing antibodies that go with reactions don't occur in women. So generally only in men.
So, quick fun fact, Sheila and I were both infusion nurses before we came to this role at Magic. So we infuse many Fabry patients with Repligal at the time. And as infusion nurses, we are taught, or we're that company educated on the starting of the IV, the maintenance of supplies, mixing the med, but we don't learn all this about what is Fabry. So if you have VRT, are the expert. We know that you're stuck with your infusion nurse for anywhere from an hour to up to 4 hours. So share with them what you're learning. Go on this little journey together. I mean, we had our favorite shows that we watched with our patients, but maybe you watch a webinar and you teach your friendly neighborhood infusion nurse what you're learning about Fabry. So there's a lot of information that they don't know. So as Dr. West said, the clinics now see all the infusion records and we know what we're looking for. But I think at that stage when I was infusing, I think you were similar, we don't know. I don't know all this. So share with them, teach them.
Yeah, meaning you need to use your voice, right? They can't read your mind. And you need to use your voice because you are the expert about your body. And please share that with someone, whether it's your prescriber, your nurse, and it will go to the report and we will see it. So please verbalize it.
All right,
We have
Julia.
one final question. It's just how often do women who have Fabry pass this disease on to their sons? Is it common? So I don't know if we want to touch on this and then we can close.
Yeah, that was a few slides ago, so maybe you joined late, so go back and watch it again. But yes, so women are XX. You have two X chromosomes, and you will pass one of those on to either your daughter or your son. So there is a 50% chance that you will pass that on to one of your children.
Thank you. That's great. And yes, we do have it on a few of our different webinars, so you can watch those in more detail if you want as well. Thank you everyone for joining tonight, for your time, and as always, your compassion to Sheila, Rebecca, and Dr. West. Is what an incredible healthcare team that we have here in Canada. Thank you everyone for joining tonight, and have a good night and take care. See you next time.
Thanks.
Take care, guys.
Okay, thank you.
Thank you. What? Merci beaucoup. Bye.
Bye.